to the HDSA Caregivers Corner webinar. Today we're pleased to welcome Dr. Deborah Blue, who will be presenting on palliative care in HD. Dr. Blue is the medical director at the Hospice of Wake Forest. Dr. Blue is the medical director at the Hospice of Wake County. She has 37 years of experience in healthcare, including 12 years as a nurse and 20 as a physician. Dr. Blue is board certified in family medicine and hospice, as well as palliative medicine. Before I invite Dr. Blue to begin, I'd like to take a moment to review how you can ask a question, as well as how to access the webinar after this broadcast. Your questions will be answered after the presentation. However, you may send a question anytime during the presentation. To send a question, just go to the control panel that appears on the right side of your screen. After typing in your question, just hit the send button. You can view this webinar again approximately 48 to 72 hours after broadcast, when it will be posted on the HDSA website. To access the presentation, just go to www.hdsa.org, and they will be archived in the Living with HD section, as well as in the frequently accessed links on the homepage. There will be an accompanying PowerPoint presentation that will allow you to print the slides, as well as a PDF of additional information. And now I'm really pleased to welcome Dr. Blue.
Good morning or good afternoon, depending on which time zone you live in. I was really honored to be able to speak at the meeting that was here in Raleigh in June of this year, and hopefully this presentation will be of some use. There is a disclosure here by HDSA, and that I think all of you can read. And I too need to just disclose that I have no financial relationships with any commercial interests, and actually this presentation is free of any commercial bias. It's interesting in the span of my career, the teaching was some 30 years ago, that about 25% of everybody just died very suddenly. And that statistic has changed so much over the years that now only about 10% of people actually pass away quickly and never know what happened, which means that 90% of us really endure some sort of chronic illness with gradual decline and eventual death. And I think this has really prompted a firestorm of information in the lay press these days, which is really great. There are a lot of articles out there these days on palliative care and how we can make a difference. And so it's, in my estimation, just kind of a totally, what we see now is totally different from what we saw 30 years ago. And so it's prompted a lot of questions, and I think a lot of what we read out there these days really try to help answer this. Questions like, what kind of help is there as people prepare for the end of their life? Where do they start in thinking about that? How do they get the services that are available? And a lot of folks worry, too, about how these services are paid for. And the good news is there's not much to worry about there, but we'll go over all of that during the presentation. And people often wonder, too, how do they know when it's time to call in palliative care? And then what can palliative care and hospice do to help me or a loved one I like to start every talk that I do about this by trying to answer this question, and that is, when do we really start planning for the future? And the very best time is now. Currently, about 80% of the patients I see are trying to make decisions in crisis mode, and that's a very tough time to start doing decision making. And I think that for all people with any type of illness, that to start that planning early in the course so that family knows what your wishes are is the very best way to handle that. And everybody should really do this. There are communities where 85 or 90% of the community has advanced care directives, and in places where they've been really active in getting this done. And then other places that are closer often to what I see here, where maybe 20% of the folks have done this. So I'll describe what that is to you, and hopefully give you some resources where everyone can really work on this sort of thing. Advanced care planning is just kind of the broad category or the broad description of having a living will, or what we now call advanced directives. That's one piece of advanced care planning. Another piece is to have a power of attorney for health care. People often have a durable power of attorney, too, who handles all the rest of their affairs. There are a lot of documents available out there that are quite user-friendly these days that really help people lay out what their advanced directives are and how to get power of attorney for health care in place. So there are sites that are online. Lots of times if you go to your state website, they'll have information on that. There are also organizations like 5 Wishes, which has a nominal fee associated with it, but it's a very nice document where people can walk through that decision making. Some communities even have classes that you can take where there'll be a healthcare professional that can help people walk through some of that decision making too. This sort of thing should really be free too, or have just a minimal cost associated with it, usually not more than $5 or $10. A very important thing to know about this, though, is that each state has their own, and they're really not transferable from state to state. So if people move, or as was my practice back in Wisconsin, about half the patients were there 6 months out of the year, and the other half of the year in Florida, they really need 2 sets of these documents to really cover themselves. The advanced directive really allows you to document your wishes, and and actually in a very explicit fashion too. In fact, one of my favorite advanced care directive documents at the end asks the question, even, is there something that you would like everyone to know? And I have seen people write in the most beautiful, most eloquent statements regarding their life, and so it can be a place for your wishes, but it can also be a place where you can make those kinds of statements. You should really file a copy with your physician or physicians and the hospital, and then have a copy at home as well. Most states now have programs too, because the EMS can't really honor a written document and start reading through that when somebody's in an emergency state. A lot of states have different programs. In North Carolina here we have something called an out-of-facility DNR, and it's just a gold sheet of paper that has this information on it, and it goes wherever the patient goes. And if they're home, it's usually on the refrigerator. In Wisconsin, we had a plastic band that had the patient's name, the doctor's name, their address, that sort of thing in the band. And if they had that band on, EMS did not start resuscitation. So like I say, they're not going to be able to read through documents in a crisis. So those wishes should be well known, and you should find out what your state requires to help protect you from that if that is not your wish. Documenting these wishes, though, should cover things like resuscitation, hospitalization, whether or not you would want tube feedings, mechanical ventilation, IV fluids, and other treatments like that. And then update the documents as feelings or opinions as your wishes change. A healthcare power of attorney is a separate document, and that should really be determined in advance as well. And this is someone that a patient would select to represent them if they can't make decisions for themselves. And there's a couple of real important points here, and one is that the patient has to be declared incapacitated and unable to make their own decisions. And most states require 2 physicians or a physician and a psychologist. I tell people to make sure that they really have someone who will act in accordance with their wishes or in their best interest. Lots of times we see folks who want to overturn people's living will, and that's really not the point of having a healthcare power of attorney. They are really there to help make decisions that could not have been reasonably covered in the advance directive. So if somebody needed surgery, this person would be able to decide whether that's a good idea or not. But they're really not assigned this task so that they can overturn your wishes. So make sure you've really got someone that can really represent you. And typically people select a spouse, but often they pick a child. Sometimes I see families where they hand this task to all the children, and sometimes then it's a little hard to achieve consensus, but I would make careful consideration of that in preparing that document. So organizations like nursing homes, skilled facilities, patients, I think I get asked these questions almost every week. How will the folks taking care of a person, or how will that person themselves know when they really need a different type of care, when they really need hospice or palliative services. And what we typically see is that a person has an advanced chronic illness, and that it has advanced to the point that it's just not responding well to measures that have been used to either cure or at least keep that illness in check. And the patients themselves often identify a really poor quality of life and will tell you that they're suffering. What I really see on the part of caregivers is that they worry incredibly about that person. They're often fairly sleepless at night, and sometimes they're losing weight, and sometimes they don't look so well themselves because of the degree of worry that they have. And and if they need support and someone to talk to about the many issues of that illness, that's really a time to bring in palliative care or hospice services. So I'll talk about the 2 different programs, and before I get into the specifics, palliative care actually means a type of service or care that addresses symptoms, and really the focus is on keeping someone comfortable and improving their quality of life. For people to qualify for palliative care services, they really don't need to have a life-limiting illness. Well, I take that they don't need to be down to the last 6 months of their life. They need only have a life-limiting illness. And as we'll talk about in a minute, Medicare has very strict guidelines about physicians predicting whether someone has roughly 6 months or less to live, and we'll go into that. So palliative care, the way we provide our service here in the program that I run, we have physicians and nurse practitioners, and we cover patients in this community who are hospitalized, patients who live in nursing homes or assisted living facilities, and we also see patients in their homes. Some palliative care programs run clinics too, or will have a day or two a week in a doctor's office where they set up this service. The care is really directed at treating symptoms like pain, anxiety, delirium, and it uses a team approach that includes social workers and chaplains. Can everyone hear me? Yes. Hello?
Hi, Dr. Blue. I can hear you.
Oh, you can. Okay. I was being flashed a message here on the screen that says my network connection has been lost, and now it says it's been reestablished. So hopefully there was not a lapse in this presentation. So our palliative care service really focuses on treating symptoms like pain, anxiety, delirium, and we work in concert with our home health nursing division, as well as our social workers and chaplains. There isn't a stipulation regarding life expectancy. So our program sees people that may even have a year or two remaining. They can still be pursuing active treatment of the illness. And like I said, the goal is really to improve the quality of life by providing the patient and family assistance in managing those symptoms. I think key to palliative care is that there's really less focus on the disease and more focus on comfort. It's really a holistic approach that focuses on physical, psychological, and social aspects of chronic illness. We sometimes assist with family conflicts regarding care too. Sometimes it's near all-out battles between family members, but we really try our best to mediate those situations too and really achieve consensus. The care can be provided by physicians, nurse practitioners, and PAs. And this service is paid for by Medicare Part B, like a regular doctor's office visit. So if someone has supplemental insurance, that pays that 20% copay. So we'll switch our focus to hospice. And for hospice care, Medicare's requirements are that somebody does have an end-of-life diagnosis and is expected to live 6 months or less if the disease follows its normal course. And the patient's attending physician is the person that needs to certify that, and so does the physician working for hospice. People can refer themselves to a hospice program, but they do need an attending physician who will sign them in. Hospice is really a team approach to end-of-life care, and it heavily involves the nurses, the social workers. There are aides that are available for daily care. There are also spiritual care personnel and physicians. There are also a host of volunteers. Our program has over 400 volunteers and who provide an enormous amount of comfort and assistance to families. With hospice care, too, people really have to be planning no further curative care. So what that means is that if someone has cancer, that they are no longer receiving chemotherapy or aggressive forms of therapy. With Huntington's, often folks are still on their medications that do help with their symptoms there, though. So we certainly see that with our Huntington's patients. So a lot of folks remain on oral medications that help palliate the situation. They're just not pursuing aggressive curative type of care anymore. The goals of care really are control of symptoms and assisting the patient and family and really easing them through this transition in life. So what people can expect from hospice personnel is some assistance with decision making and the kind of caring and comfort that can really allay fears and really help families navigate through this transition. Almost every week I still get asked, isn't hospice just for cancer patients? But probably for the last 20 years or so, the focus has really shifted. And currently about 42% of our patients have cancer, but the rest have all sorts of other illnesses, principally heart disease and lung disease. This service is covered 100% by Medicare Part A, and a lot of people would call this the crown jewel in Medicare's crown because it is a covered service, and families are not billed for these services. I think I may have actually finished a little earlier than I anticipated, but I'm happy to take questions. Hello?
Hi, Dr. Blue. You just got a question. If a person who has HD is getting a nutritional supplement, such as Relieve, would a nutritional supplement have to be stopped for hospice to begin?
Yeah, that's an excellent question. And here at our program, some of our patients actually even have feeding tubes and that sort of thing, and so they do not need to stop nutritional supplements.
Thank you. We just had another question. There's an HD patient that was put in hospice after choking issues. He's fine now, and he's better than he's been for months. Will he be able to stay in hospice during the years it may be before the final decline?
Yeah, you know what happens in that setting, because sometimes we do see people, in fact, probably about 10% of our patients improve after starting hospice care, and for a variety of reasons they improve. And what we do is periodically, at what we call certification periods, take a hard look at the patient to see if we think that they still have 6 months or less to live. If they do, we keep them on service. If they improve so significantly that they look like they may have another year or two, we graduate them from our program, but take them back when the time arises.
Thank you. One more question. Do any of these palliative strategies reduce the need to be in a nursing home?
You know, lots of times I think it can, because in treating the symptoms and the nurse, and I think particularly through the nursing education that families can receive on kind of how to take care of someone, particularly issues like how do you get somebody turned, and how do you get their pills into them. So we do a lot of teaching as that decline happens, so that families can be comfortable with that level of care, and indeed a lot are. And then sometimes, though, it works out better for everyone, it seems. You know, and so we end up helping guide them through that decision making over whether to place someone in a facility or whether to keep them at home.
Thank you. One more question. How do you recommend that people talk to their loved ones about reaching the end-of-life stage with HD and palliative care?
Yeah, that too is a very good question. I know when I've had to approach families in the past who were really at this point and kind of needing to discuss these things, sometimes the patient hasn't wanted services, but you think that sometimes the spouse will be really much more served by these services or could really use the services. And so I think sometimes that needs to come into play too. I think for someone to be honest with someone and talk to them about the assistance that they need in someone's care. But I think just the real piece, you know, about this decline really comes from the heart, and sometimes we're real, you know, doctors are the same way. Families can be very afraid to talk to patients about that, but they know. In fact, it's interesting to me how often I've been asked to not tell somebody that they're in hospice or that they have some dreadful disease. But if you ask them, you know, just kind of where they're at or what they think about what they're going through, they'll look at you and tell you. So sometimes I think we're afraid, but don't need to be, because I think the patients really know. And so I think it's important to just speak from the heart.
Can you talk a little bit about how family members can know when their loved ones should be in hospice care? And how to tell whether they're at the end-of-life stage where it's helpful?
Yeah. You know, some of the things that we really watch for is how much somebody sleeps. And if they're sleeping more than just a little nap in the afternoon and they're 8 hours at night, and by that I mean if we start seeing people sleeping more like 16, 18 hours a day, and that's a decline from where they were a couple of months ago, sometimes those folks are just down to a handful of months left. And so I would watch for how much somebody sleeps. I would watch for how hard it is for them to eat anymore, how much choking they have. That's another real clue. For a lot of folks, it's when they lose their or start losing their ability to speak much and all too, though I know with Huntington's that can happen a long time before that point for some folks. So, but I would watch for decline. I would watch for it being less likely that they can get up, or that if they get up, they fall real easily, more unsteadiness, those sorts of things.
Thank you so much. That's
Sure.
very helpful. Can you talk a little bit about the nitty-gritty of getting palliative care started in terms of getting the doctor's recommendation?
Yeah, you know, when you see your primary physician, I would ask about a palliative care consultation more and more. In fact, right now, probably about 60% of all hospitals have a palliative care service, so there's usually services available there. The physician might be aware of a palliative care clinic. I hope that eventually there's enough palliative care out there that people don't have to travel long distances to receive those services. But I would just ask, because typically a primary care doctor would make that referral.
Thank you. Can you talk a little bit about how Medicare Part B works in terms of palliative care?
Yeah. What is done with Medicare Part B is that a bill is submitted just like a regular doctor's office visit. So Medicare pays 80% of, not the entire bill, but 80% of what they think the bill should be, I guess is the way to put it. And then people's supplemental insurance picks up the other 20%. If they don't have supplemental, that would be billed to the patient as a copay, like with regular doctor's office visits. And the other part that Medicare doesn't pay, beyond that 20%, nobody has to pay. So if an office bill, say, is the sorts of things I've seen, like around $200, let's say, and Medicare decides that they pay $60 for that visit, they would pay 80% of that. The insurance would pay the other 20%, and nobody's responsible for the difference between the 60 and the 200.
Thank you. Let me, in terms, I have two specific questions. Can you talk about, in terms of what's best for the individual, do you think it's better to use home services or to be in a care facility? This is from a caregiver whose sons are 35 and 36, and they're entering the end stage, so she's in the decision-making process.
Yeah. You know, my experience with Huntington's is that folks can be so active that I think for one person to be able to manage that person, or to be able to manage two people, I would think would just be physically and mentally overwhelming. We just recently had a patient at our hospice home at the end, and he required really one-on-one attention around the clock. And so I think the logistics of it could be difficult for a person unless they had a whole kind of team so that person could get a break.
Another sort of specific question. Can you talk a little bit about feeding tubes and what your thoughts are about installing a feeding tube when individuals can no longer swallow?
Yeah, that's a very good question. I'm actually sitting on a statewide committee regarding feeding tubes in this state too. And I think that many times feeding tubes are posed like they are an answer, that they'll fix the problem. And I think the reality of it is with feeding tubes is that I see a lot of people aspirate because that is just a liquid that's going into their stomach. It refluxes easily. That means it comes up the esophagus very easily, and it can end up in the lungs. And so it's not uncommon within a day or two of a feeding tube going in to see aspiration pneumonia already. And so I see a lot of complications related to feeding tubes. And I think that what I see in families is that these feeding tubes were billed to them as being a solution to the problem when really I find them to be very imperfect, because when we eat solid food, it tends to stay down in our stomach a whole lot better than when we take in just liquid. And it's that liquid that rolls right back up that causes that pneumonia. And I think for a lot of people, it really postpones the inevitable. And I would look at somebody's level of functioning, take a hard look at that to determine if a feeding tube would be appropriate. There are some cases where feeding tubes are, so we see maybe somebody gets say, cancer in the neck or the esophagus and can't swallow, but under normal circumstances, maybe months and months and months away from passing away. And there, being able to get some nutrition into them can help while they sort of do that end-of-life work. But often we see feeding tubes, much more often, going into individuals that can't get out of bed anymore, can't speak, can't indicate their wishes, and so I think for folks that are in that state, it really can prolong the inevitable. Though, like I say, I've seen feeding tubes shorten people's lives plenty of times too, that instead of just allowing them to sort of nibble what they can, we put feeding tubes in and they die of aspiration pneumonia a week later. So, so I think they're fraught with, I think sometimes controversy, I think sometimes fraught with problems as well. And I think that is, particularly for Huntington's, is a discussion to have very early on in the disease so that someone can really make their wishes known.
Thank you so much. Can you talk, I just got a question about, it's amazing how much experience you have with HD. Can you talk about how you became so familiar with HD patients and their families?
Yeah, in talking to hospice colleagues across the country, many folks don't have an awful lot of experience, and I think it's in part because the disease is relatively rare, though someone from the HD community not too long ago told me that in a way folks or families with HD kind of hide, and that broke my heart to hear that. So I feel very, very strong about and very committed to serving folks, and I would hope that people don't feel that they shouldn't present themselves for services. So we are very committed to taking care of everyone and my experience this summer too with the group, I was just completely awestruck by the support out there, and that conference was amazing. So,
Thank you.
Yeah, and I mean, I started this career as a critical care nurse, and a good deal of me really realized how sometimes that job was so frustrating because you wanted to do more, but there was nothing more to do, and for other folks, you were doing things that should never be done to them, and there was just a lot of conflict, and it was, in fact, a good deal of why I went on to medical school, because I really wanted to be able to help people sort those things out in their life by having a long-term relationship with them. But as my career evolved, I really realized that what I really needed to do was really help people with this final journey in their life, and really made a career out of that. And I think sometimes people wonder, why would you do that? But it is that commitment, it is that caring, and it is understanding what that journey is like that makes me do this every day. So it's a good place to be.
Thank you so much for what you do. I have another question for you. Is it true that, or what are your feelings on the pain that's caused by the feeding tube, and how is that pain dealt with?
There is pain when they do the initial insertion, and people have anesthesia to have a feeding tube put in, and that site may be painful for the first several days, but it tends to heal, and it tends not to cause any particular pain after that unless it gets infected or anything, and sometimes the sites get infected, and they can get pretty red and tender, and the treatment there is really to treat the infection.
Thank you. Another question just came in. There is a patient with end-stage HD. The patient is choking a lot lately. What can be done when the patient is unable to eat for a couple of days, and would this situation be the time to have hospice?
Yeah, if the patient is really starting to choke a lot, and particularly if the patient has started losing a lot of weight, that phase toward the end where the weight really just seems to fall off, that really is the time to call hospice.
Thank you so much. If anyone has any more questions, please send them on. We have a little bit more time left for questions. Okay, so we have no more questions coming in. Thank you so much again to Dr. Blue for presenting and for everything you do.
Oh, thank you. Thank you so much.
And again, for everyone on the phone, as a reminder, in 48 to 72 hours, we will make this broadcast as well as the PowerPoint available for your download. Thank you, everyone.
Thank you.